let's get started, shall we? Today we're going to talk about a topic that really doesn't get discussed a lot just because it's not seen a lot, but it's important to know about these things when they do come up. Adrenal incidentaloma. Well, what's exactly an incidentaloma? Incidentaloma, when you absolutely positively may or may not have a genuine problem. So you just randomly find this mass on CAT scan and no one has any idea what that is. Now, we'll get into talking about exactly what the definition of that is and when it's not an incidentaloma versus when it is one. So again, here you go. An incidentally detected adrenal mass is an adrenal tumor not suspected prior to imaging. So you had no idea. Better? All right. Sorry, technical problems. You had no idea walking into this CAT scan that they had any adrenal mass. They had no symptomatology beforehand. You weren't looking for it whatsoever. Okay? So how often does this occur? Autopsies have shown the prevalence of an adrenal incidentaloma anywhere between 1.4 and 8.7%. So quite a bit. Approximately 12.5 million Americans are found to have some sort of an incidental adrenal tumor. Men essentially are equal with women. But you actually they're found more commonly in women just because some of the hypersecretory tumors that you find, say like hyperaldosterone tumors, are actually more common in women, and as well as pheochromocytoma. We'll get into that a little bit as well. It does increase with age. So you have if you're greater than 50, you have a 3 to 7% chance. If you're greater than 7, you have a 7% chance approximately to have an incidental adrenal tumor. So CT scans out there, when you find these things, obviously, with how much we like to image people. We like to essentially nuke everybody we possibly can coming through the ER for some reason or another. So finding these tumors has gone up significantly, which has led to actually essentially better prognosis with adrenal cortical carcinoma because, again, when you find them incidentally is better than when you find them symptomatically. Approximately 62 million CT scans performed a year nationwide, okay? Of those, anywhere between 300,000 to 2.7 million incidentallomas are found per year from cats, okay? But again, they're also found if you're getting an ultrasound for some reason. Sometimes they'll kick over the kidney, say for a right upper quadrant ultrasound, they'll find incidentaloma that way, or MRIs or PETs or whatever it may be, they may find some incidental mass sitting in one of the adrenal glands. Now, what's important exceptions to this when it's really not an incidental tumor? If they had any history of extraadrenal malignancy, say, again, lung, bowel, breast, panc, anything like that, especially lung, the CAT scan protocol is to go below the kidneys barely to catch the adrenal glands because there is a chance of having metastasis from lung cancer. That's one of the places you look for. It's one of the reasons we look at liver too when we get a chest CT. But adrenal nodules, if they have extraadrenal malignancy, if there's a nodule, you have essentially a 0.5 to 3/4% chance of it being a MET. If they're greater than 3 centimeters, you're almost guaranteed that's going to be a MET if they have some sort of extraadrenal malignancy, okay? And again, even if you don't see it, 1/4 of these people that do have carcinoma at autopsy, they are found, when they do autopsy, obviously, are found to have some sort of adrenal malignancy. So it's fairly common with people that have, again, lung, bowel, breast, and pancreas. Those are the most common things that are going to met to the adrenal gland, okay? Again, patients with a history of Men's syndrome. If they have Men's syndrome, that's really not an incidental finding. That's in your scroll down, obviously, for men. Guess what? There's adrenal tumors associated with that. If you're ordering studies for evaluation of hypertension, again, hypercortisolemia, pheochromocytoma, hyperaldosteronism, if you're looking at those type of things, then you're really not incidentally finding the mass. You're actually looking for something. So why should I care? And that cutoff, well, we'll just talk about it anyway. There's 2 main reasons you care about incidentallomas, okay? One, are they malignant? Any mass, you got to think it's malignancy. I don't care where it is. I don't care what it is. If they have a mass, unless it's some sort of something that absolutely looks benign, you've got to be thinking in your mind, is this a cancer? And about 5% of those incidental findings are going to be adrenal cortical carcinomas. These are very, very aggressive lesions. Again, they're usually not found until a later stage in the disease unless they're found incidentally, okay? again, if they're found early, they have a much better prognosis. Found late, the stage goes up. The higher the stage. If you get up to a stage 3 type of disease, we'll go into that a little bit what the stage is. But if you get to a stage 3 disease on adrenal cortical carcinoma, you're looking at approximately a 12 to 20% 5-year survival rate, where if you find them incidentally and they're a stage 1 or 2, you're looking at anywhere between a 50 to 70% 5-year survival rate if you can get them out of there. The other reason is it hyperfunctioning? And that's the other question you need to ask yourself. Is this something related to Conn syndrome? Is it Cushing's? Is it Pheo? Okay? Those are the two things you need to ask, malignant or hyperfunctioning. Big differential. I don't expect you to know it. We really won't go over it. The thing you really need to know is benign non-functioning adenomas. That's going to be by far and away the most common. And then adrenal lipomas. Okay? By far and away, those are the things. If they're benign non-functioning, that's what they're going to be. Now, if they're malignant non-functioning, your most common is going to be adrenal cortical carcinoma. And obviously that's going to be a concern. Now what about hyperfunctioning masses? The most common one's going to be Pheo. Okay, the next you're looking at essentially Cushing's, hyperaldosteronism, and you have to click it out into subclinical Cushing syndrome versus frank Cushing syndrome. We'll get into that. You also have masculinizing tumors or androgen secreting tumors. And then obviously there's pseudoadrenal tumors. So they look like they're adrenal tumor, but really they're a hypervascular, something come off the liver, or they're a lymph node, or a pancreatic mass, which isn't good in itself. So obviously there's a lot of things surrounding the adrenal glands. They're not that big of a thing. So you obviously could have something else kicking in there. So let's get back to the workup. Okay. So you instantly find an adrenal tumor. Why? Now you need to go back and redirect what some of your questioning was. Okay, you need a thorough endocrine evaluation. Do they have a history of hypertension that's uncontrolled, that you can't control? They got headaches, syncope, weight gain, urinary frequency, viralizing symptoms. Okay, any history of endocrinopathies like Men's syndrome, things like that. Again, physical exam. Do they look like are they obese? Muscle wasting, abdominal striae, skin atrophy, you know, the typical buffalo hump for Cushing syndrome, the Quasimodo looking guy. All right. So evaluation of your functional status. Now 67 to 94% are non-hypersecretory adenomas. Again, so a lot of these are just going to be benign adenomas. However, 10% are hormone secreting associated with subtle symptoms of hormone excess. All right. So again, you're always going to be looking if they're secreting hormones or not. And we'll get into cortisol secretion, Pheos, and Conn syndrome in just a second. But those are the main players, okay? So Cushing's, subclinical Cushing's, frank Cushing syndrome, Conn syndrome, and Pheos. What are your lab values going to be looking for? Now, if you're looking at pheochromocytoma, you're going to start working them up because you can't control their hypertension and they have this adrenal mass. Or, let's rephrase this, and you're thinking they're going to go to surgery for some reason. Let's say they have an appy and all of a sudden, for me, this is important, and you get nailed on this on oral boards. Let's say you got someone that has appendicitis. They got a CAT scan. They got appendicitis, but they also have this 3.5 centimeter looking mass in their adrenal gland. Well, you better get something pre-op and make sure not, because you take them to the OR for something like that, you could easily kill them and put them into a Pheo crisis. So plasma metanephrines versus 24-hour urine metanephrine and VMA. 24-hour urine metanephrine is a little more sensitive and specific than plasma metanephrines are. It's obviously not always available, but usually you start with that one, maybe get a plasma. Hypercortisolism for Cushing syndrome. The milligram dexamethasone suppression test, or there's a 24-hour urine. This is more specific, the milligram dexamethasone suppression test. If that does come back positive, then you got to do a high dex suppression test to decide whether this is coming from a pituitary source or an extra pituitary or extra adrenal versus extra adrenal source. Hyperaldosterone or CONS, you're getting a plasma renin to aldosterone ratio. Okay, this is low yield in someone who's normal kalemic and non-hypertensive. That's the thing essentially you're going to be looking for. Okay, they're going to be low. They'll have hypertension and they'll have low potassium. This is actually a highly undiagnosed condition. People that it's essentially about 10% to 12% of people that have refractory hypertension will actually have a con tumor that just really isn't ever diagnosed. You just need to be aware that they keep having low Ks and hypertension, and maybe something you want to look into and get a PRA to PRC ratio. And then again, viralizing tumor is not as common, but you can get serum DHEAs. So Cushing's. We talked about the low dex suppression test. You give them 1 milligram of dexamethasone administered orally at 11 p.m. Okay, you bring them in the next morning. You run a plasma cortisol at 8 in the morning because, again, you want to see if it suppresses. Now, normal individuals will suppress below 5 micrograms. If they're above 5, then you're essentially got some sort of Cushing's pathology. Again, you can do a 24-hour urinary free cortisol if you need to. And if it's greater than 100, it's essentially diagnostic as Cushing's as well. But usually we'll go for the low dex first. So again, here's a little breakdown and algorithm of it. Hypercortisolism is suspected. So you get either 24-hour urine or you go for the overnight milligram dexamethasone suppression test. If it's positive, you got to go do a high dexamethasone suppression test. After that, you get an ACTH. All right. If their ACTH is high, then it's a pituitary source. You need to get a pituitary CT or an MRI with gadolinium to see if they have a pituitary tumor. You also maybe need a petrosal sinus sampling. I ain't doing that. I'll tell you that much right now. If it's very high, if it's slightly high, then you got this going on. If it's really high, then it's some sort of ectopic source. You're going to need some sort of CT imaging. If it's low, then you're thinking an adrenal source. You need an adrenal scan. And we'll get into this, but there is a adrenal CT protocol because you have to have it certain slices. They have to give them so much contrast and see what the washout is on it. Now, what about Conn syndrome or hyperaldosteronism? A PAC of greater than 20 nanograms per deciliter and a PAC to PRA ratio of greater than 30 are pretty much diagnostic with almost a 90% sensitivity. So again, you're going to get a PAC to PRA ratio. That's going to be your first line lab test for that. Now, if you have a serum potassium less than 3.5 and a urine potassium excretion greater than 30, it's also going to support your diagnosis of hyperaldosteronism. So come back to the algorithm. Hyperaldosteronism suspected. Get a PRA to PAC ratio greater than 30. Here's the numbers. Greater than 30, then you're suspecting it. Okay. You go for a 24-hour urine potassium greater than 30. If it's positive, you're going to kick over here and get an adrenal CT. The other thing is adrenal venous sampling. We don't do that here. They'll do that some other places. Essentially what you're doing is you're going through the femoral vein. You get your IR person to go through the femoral vein. You'll stick it right into the adrenal glands. And you'll give them a trial of ACTH right into the vein and see what it does. Now this is actually very specific, but it's, again, you have to be at a certain facility where they're going to do that for you. Where this also helps out is if, again, you have 2 masses in the adrenal glands, you don't have just one, and you want to know where the actual mass, the hypersecretory mass is. It may not be both sides. So you need to find out. You don't want to go in there and say, oh, take the wrong adrenal gland, and then guess what? They still have Conn syndrome. So a lot of times they'll use that, or sometimes even intraoperatively, they'll take a stick and see what they have. Wow, that's over there. So again, masses, most of them are non-functioning. You're talking about Cushing's. Or, no, I don't know what that says, sorry. So looking at subclinical Cushing syndrome, again, you got to do a DEX test. Check their ACTH. Conn syndrome, we're just running over again. Elevated plasma aldosterone concentration and a PAC PRA concentration greater than 20. And then you may have to confirm with a fludrocortisone suppression test. There are a lot of false negatives with this. You have to have them off their aldactone. You have to have them off their blockers, ACE inhibitors. There's a few things you have to have them off, or it's going to give you a false negative or a false positive. Theo, serum metanephrines, and normetanephrines are your most sensitive study. You can also do a 24-hour. And remember your rule of 10s. It's always going to be on your boards if you ever get a Theo. 10% of Theos are bilateral, 10% are extra-adrenal, 10% are in children, 10% are malignant. Guaranteed you'll see that. Guarantee it. If it's indeterminate, you may have to have a clonidine suppression test, but you really don't use that much nowadays. You can also get a MIGB scan. And that'll help you look not only the pheo, but there's also the nice little board eponym fodder, the organ of the Zucker candle. When your adrenal glands embryologically are made, right, they carry down the periganglionic area and down through next to the aorta. Sometimes you'll have an extra adrenal source called the organ of the Zucker handle, which is most commonly the aortic bifurcation. This will also produce norepinephrines, okay? So something to remember, put in the back of your mind. So treatment of functional tumors, what are you going to do with them? It's essentially take it out, take it out, take it out, and take it out, okay? You may have to pre-op get these people in a better position. Again, if their potassium is really low for cons, you're going to have to replace that. Cushings is essentially you can get it out, and they have very good results for both laparoscopic adrenalectomy for both Cushing and con syndrome. Their symptoms essentially resolve in 80 to 95% of the time. Okay, they have very good results with taking that adrenal gland out. Now, pheo gets sticky. Now, you're going to have to preoperatively block these people. And remember, you don't start your beta blockers first. You always alpha block them first. So how do you do that? Alpha block them down. You're going to use phenoxybenzamine. Okay, you're going to start at 10 milligrams twice a day, and you're going to increase 10 to 20 milligrams per day until you get them essentially relatively hypotensive. Okay, you want them down, and then you're going to start beta blocking them. But you've got to do that 1 to 3 weeks in advance, preferably at least a couple weeks in advance to try and get them controlled before you ever even think about taking them to the OR, or it's going to be a bad day for you. Now, if you have a pheo crisis intraoperatively, you're going to have to bring them down. You may have to use nitroprusside, whatever you got to get them down. You're going to have to get them down and control them. What about subclinical Cushing syndrome? This one's kind of controversial on whether they really want you to take it out or not. It's getting more to the point that they are saying take subclinical Cushing syndrome out because they're having better results. But previously it was a kind of a gray area. But they do have increased cardiovascular risk factors with subclinical Cushing syndrome. 45% of hypertension, you're going to have increased impaired glucose metabolism, obesity, dyslipidemia. So all those things are going to put you at a cardiac risk. So if you look at some of the numbers, you can see here. So if you don't take it out, okay, unchanged, but you also have a deteriorated number. Now if you do it after adrenalectomy, you have unchanged individuals as well, but you have no deteriorations. So they're moving more towards doing some sort of adrenalectomy for subclinical Cushing syndrome. Again, it just pops it up. So what if it's all negative? You've done your workup, and they're absolutely non-hyperfunctional, okay? 10 to 20% of the adenomas may have a negative, may have a negative biochemical workup. So you still got to follow these patients. And they may develop a hyperfunctioning on a 5-year follow-up. Most of them are going to happen within the first 2 years. So what do you need to do? How do you need to follow them? You're going to repeat it 6 months and then yearly your hyperfunctioning tests for 2 to 4 years, depending on the size of the lesion. If it's a smaller lesion, you really don't need to follow it that long. But as it gets bigger, you have a much higher chance of having it be a functional lesion. You also need to continue to repeat your scans, usually to at a 6-month period of time and a year period of time. If it's stable, it's not growing, you're kind of out of the woods and don't have to worry about it as much. So again, size does matter in this. You look at the numbers here. So as it gets closer to your 6 centimeter margin, you almost 40% of those are going to be hormonally active. So what if it is completely non-functioning? And how do you know it's not malignant? Okay, imaging, biopsy, excision. Those are essentially the 3 ways you can decide whether it's malignant or not. All right, and we'll talk about imaging and how that gives you kind of some determination. Some of your differential diagnosis, again, 50+% of these things are going to be just straight benign adenomas. Aren't going to be anything big. But the killer is this. 12% of them are going to be adrenal cortical carcinomas. 11% are going to be some sort of pheo, all right? But then you get starting into Cushing's, cons, and other things. So just because half of them are there and they're benign doesn't mean that something else can't be going on. So where does CT become important? Okay, again, I was talking to you about a CT washout protocol or a CT specific adrenal protocol. You need a 10-minute washout on these people, and we'll get into why that's important. You can also MRI them with contrast, usually gadolinium, and you're getting a decreased intensity on a T1, okay, and you'll have a chemical shift as well. And you'll have that loss of chemical shift, all right? Now, That's similar to this 10-minute washout period I'm talking about, okay? PET scans are really only reserved if you have an extraadrenal malignancy source, just to see if it's some sort of extraadrenal site, and then if it's a metastasis from somewhere else. Again, some of this is going to be limited. You can't get a 500 and 600 pound person on a CT scanner. Well, that's going to limit you. Local availability. If you don't have a good MRI, then you probably shouldn't, or if you have even a better CAT scanner, you have to have a 64 plus CT spinal CAT scanner, then you may be good that way. Where you have 0.5 Tesla MRI, you're going to go with the CAT scan. And then also your radiological expertise. You have some people that obviously fellow in endocrine type of radiology versus others. So let's just talk about adrenocortical adenomas, okay? What they look like on cats. Typically, they're going to be small, less than 3 centimeters in size, usually round, oval, smooth margins, the typical benign looking type of mass like everything else, okay? They're going to be homogeneous, they're going to be low density compared with the liver. And they're usually solitary and unilateral. Now, CAT scan, if you guys are familiar with Hounsfield's units will look at how dense something is. So it'll give you an idea of, say, blood versus ascitic fluid versus anything else. So the more dense it is, the higher your Hounsfield units. So these things are usually going to be less than 10 Hounsfield units with contrast, and they're going to be less than 37 with of Hounsfield units 30 minutes after your contrast administration or after washout. They're going to be iso-intense to deliver on T2 weighted images. There's really no presence of necrosis, hemorrhage, or calcifications. Those are going to be more reserved for your adrenocortical carcinomas or even your PHEOs typically. Okay, they usually don't grow over time. You get your repeat CAT scan, they're usually not going to be bigger. That doesn't mean they can't be, but they're very slow growing. So here's a good picture of one. Okay, so you got your aorta, you got your diaphragmatic crust coming off. Here's your liver, obviously, stomach, spleen, and right there, you'd have kidney here eventually, but right there you just have a very round, oval, good margin mass, and it's essentially isodense with the liver there. There's no non-homogeneity to it. It looks pretty benign, okay? That's your typical adenoma type of looking adrenal mass. What about adrenocortical carcinomas? They're typically going to be larger, typically greater than 4 centimeters, okay? Irregular, unclear margins. They're going to be non-homogeneous with mixed densities, okay? They're, again, usually solitary and unilateral. You're usually on one side. CAT scan results greater than 10 Hounsfield units, okay? Without contrast, and greater than 40 on your washout. They're going to be hyper-intense on MR and T2 weighted images. There usually is going to be necrosis, hemorrhage, or calcifications, and they're usually rapidly growing. Probably, if you see one, you're not going to be getting a repeat CAT scan. You're probably going to be referring to somebody to take the freaking thing out. So here you go. There's a big one. So you got a kidney on this side. You're going to see it displacing your pancreas and your aorta. Spleen's not even in the picture anymore. Colon's pushed up as well. And you can see how non-homogeneous this thing is. It's most likely got necrotic dead tissue in it. Okay, it's very irregular. It just looks nasty. That's what a typical adrenocortical carcinoma is going to look like. So what about PHEOs? They're again going to be typically larger, but they're going to still be round and smooth margins. They're not going to be homogeneous though, and they'll have a cystic type of texture. Again, they're usually going to be a little more vascular. They're also going to have a higher Hounsfield units because they're more dense because of all the blood, the vascularity to it. They may have necrosis, they may have hemorrhage because again, you got blood flow through there, and you may have some infarcted areas through it just because it can't keep up with the blood flow it needs. But they always usually go very slow. So again, here you can see one. It's pretty round, okay? It's not homogeneous though. You can see septations coming through the area. You can see this ring around it, but it doesn't look like a typical adrenocortical carcinoma because it's not irregular in shape, all right? Again, you're looking at adenomas. The reason why they look that way is they've got high intracellular fat content, or they're very lipid rich. So they're going to be low attenuation on CAT scan. And they wash out rapidly because, again, there's not as much vasculature. They're going to get rid of it. They're going to get rid of it because they got a lot of fat. PHEOs retain it much longer just due to the vascularity, all right? Now, here's the difference. Here's a benign one. Okay, see how round it is? It's hypodense, but if you pop over to the other side, very septated, very non-homogeneous, irregular. You can almost see some streaking, nasty looking fat next to it. That's adrenal cortical carcinoma, and that just gives you a picture both ways of what each will look like. Here's a really large one coming off the right. And then these are on MR. So you have a T1 weighted image, and you have a T2 weighted image. You can give you kind of a different look at it. You can see the liver up here. Again, it's hyperdense compared to the liver. Same thing here. So there's bilateral adrenal adenomas. This one's large. That one would come out. And then you got an adrenal cortical carcinoma actually invading into the cava right here. That'll be a bad day for somebody. So how do you stage them? How are you going to stage adrenal cortical carcinoma? It's very easy. You can look at your T status. It's TNM grading. T1 is going to be less than 5 centimeters. T2 is going to be greater than 5 centimeters. T3 is going to be involvement of fat. T4 is going to be involvement of extra-adrenal organs. Now, if you kick into your N status, it's easy. There's either nodes or there's not nodes. So it's going to be N0 or it's going to be N1. And M is like every other M. It's going to be Mets or no Mets. So it's either M0 or it's M1. So how does that break down into your staging? Stage 1 is essentially a T1 lesion. Stage 2 is essentially a 2T lesion. Stage 3 is going to be either a T1 or a T2 with an N1, or it's going to be a T3 with N0. And T4 is going to be, a T4 lesion essentially is going to be Mets, or it's going to be it'll be a T3, T4 with an N1 status. One of the easier ones to remember. What about PET scans? You really aren't going to use in PET scans for this unless you're looking for a metastatic site from somewhere else. PET scans really aren't going to be that great for you because unless it's adrenal cortical carcinoma, it's not going to do anything for you. It's not going to be necessarily overactively producing or growing. So you're going to have to get a biopsy of this thing if it's really indeterminate, and you got to find out if it's adrenal cortical carcinoma. Okay. It's not that great. It's going to be difficult to do. You may have to come through the lung. You may be able to go retroperitoneal through the back. It's a difficult thing to get to. It's going to be very difficult. You've got a lot of structure sitting there. You got the liver on the right. You got your vena cava abutting right up next to the adrenal gland on the right. You have on your left your pancreas is sitting there, your spleen sitting there, your colon sitting there, your stomach sitting there, your aorta sitting there. It's something that's just very difficult to get to. And you better rule out pheo before you ever go send somebody for a biopsy of this thing, or you're going to put them into a pheo crisis. The other problem is adrenal cortical carcinoma. You stick it in there, you could needle track and seed. And that's going to be not good for somebody either. So now what? You've done the imaging. You kind of have an idea what it is. Adrenal cortical tumors, okay? Most of them are going to be adenomas again. We talked about that. Medullary tumors are usually going to be pheos. And then you obviously get into cysts, hematomas, hemorrhages, infectious granulomas, or Mets. So what if it's all benign? You got nothing. And now you're looking incidentally, well, what am I going to do with this thing? If you have a small, less than 4 centimeter, benign CT featured adrenal adenoma, low attenuated, rapid washout, you can repeat your CT scan, okay? Do it in 6 months, and usually it's a 6-month period of time and then 12 repeat. If there's no changes after that year, you don't need to do any further testing, okay? If they grow significantly, say you went from a 2 centimeter to a 3.5 or to even a 4, that's a significant growth in that 6-month period of time. They need a surgical referral. If they have malignant CT imaging findings, they just need a surgical referral, period. So again, size. It's all about size with these things. If they're less than 4 centimeters, 4 centimeters is your break point, all right? Only 2% of those are going to be carcinomas. But if you get up to a 4 to 6 centimeter, you're looking at anywhere between a 12 and a 15% that they're going to be a carcinoma. That's a pretty good percentage. And if they're greater than 6, at least a quarter of those are going to be adrenal cortical carcinoma. The break point at this point in time and the indication to go for surgery is anything greater than 4 centimeters is coming out. That's the number you need to remember. That's the number I want you to remember. Okay? So again, you find an adrenal incidental mass, you do all your testing, you look for functioning. If it's functioning, it's coming out. If it's non-functioning, suspicious, it needs to come out. If it's non-functioning, 4 to 6. Non-suspicion, you can resect it or observe it. Most of the studies now are going to days if they're greater than 4, you need to resect it. Non-functioning, less than 4, no suspicious imaging findings, you can observe them. Again, CAT scan at 6 month and 12 month. If they look at it at that yearly period of time, you don't need to re-CAT scan them. Okay. So how do we do it? Okay, so any cortical tumors, we talked about that. Anything functional, and you need to get them in. I don't care. So how do we do it? So most of them done nowadays are going to be a laparoscopic approach. There was kind of some ticky-tack about whether laparoscopic versus open was still the procedure of choice. Some of it was depending on, again, size. They were thinking anything greater than a 10 centimeter lesion needed to be done openly, just because it'd be difficult to get it out of the abdomen without having some sort of seeding. But all the newer studies have saying that laparoscopic is just as effective. It has less morbidity, less mortality, less operative morbidity, less wound infections, faster out of time, out of the hospital. But with anything else, you can get deep space abscesses, bleeding, infection, and everything else that comes with it. We talked about that, decreased blood loss. You have similar operative times, decreased cost, decreased morbidity, quicker return to work. Again, the previous limitations, they were thinking you only could do it if less than 6. Now you're getting anything between 10 to 12. You can be resected laparoscopically. Some of the anatomy, just to know how hairy it is around this area, okay? If you look up here at this right adrenal gland, you see a little vein coming in. This is the first thing you want to find and mobilize whenever you do any sort of adrenalectomy on the right side, whether it be open or laparoscopic. The reason why, it comes directly off the vena cava. I guarantee if you tear that, you're going to be having a bad day, especially if you're doing it laparoscopic. Your whole operative field is going to fill with blood about that fast. And I mean, it happens, but so your first priority is to mobilize this area, get underneath there, clip it proximally, clip it distally, and cut that thing, and then start going for some of the arterial arcades coming down from the phrenic or coming off the renal. That's your primary thing. On the left side, you can see it popping up off the adrenal, or the renal vein. Okay, you're going to be finding that. But then your arterial supply is usually arcaded. It comes in multiple branches. There's not a single arterial branch coming into it. Now, the right adrenal gland, again, is usually back behind the cava. Typically, there's a little bit of it that sits back behind the cava. The other thing is you got the liver over the top of it. So you have to take down the triangular ligament, use some sort of retractor, whether it's a Nathanson or a fan retractor, move that right lobe of the liver up so you can get good exposure. You're going through Gerota's fascia, moving that off, making sure you don't get into the diaphragm and give them a pneumo, okay? And then work on getting your adrenal out. On the left side, obviously you have spleen sitting over here. You have the tail of the pancreas that goes over the top of it. You'll have to mobilize both your spleen and your pancreas, flip them over, and then start working down into your vasculature and above your kidney. So again, a left adrenalectomy, you can see the spleen. It's been rotated over. The kidney's essentially been pushed out of the way, but here's your kidney, here's your spleen, liver. They moved it over. You can see your tail of your pancreas being flipped up and then getting down into the vasculature. So here's kind of a look laparoscopically. You can see the adrenal vein. This is a left. And you're getting around it. Nothing big and bad. Right adrenalectomy. Fan retractor, moving the right lobe of the liver out of the way. You can see the vena cava popping down through here. Okay, adrenal gland, kidney. There's that stupid adrenal vein that you're going to try and get underneath with most likely some sort of dolphin nose or a Maryland retractor. You'll go in, get underneath it, get it dissected. Make sure you got it well and clipped. Some people will use a stapler, a vascular stapler on it. It just depends on how much room. If you can't get a stapler in there, then clip it off and then start working on getting your adrenal out. Again, so here's the cava, okay? There's the adrenal gland right through here. There's the stupid freaking vein coming off there. I've seen it a couple times where, unfortunately, you've got a back wall tear and all of a sudden you're bleeding. The only thing you can do is you bring an instrument down, you put compression on the proximal side of it, the distal side of it, and then you bring in a clip. Try and get control. Any questions? Not so much. Alrighty.